Thank you, Dr. Shumway and Dr. Higgins. Thank you for the association. I'm very pleased to be presenting the expert consensus document on DCD heart transplantation. I'm a little bit less pleased to be doing it during the Game 7 of the Celtics versus Bucks, which you guys can't tell is actually the game is on up here. The Celtics are winning. So as a little review for some of the people who may have come in late, there are two sort of modes of donation. So donation after brain death. So these are people who've had significant severe neurologic injury and meet the very specific criteria for brain death in this country. They then are, go down that pathway. So DCD is a little bit different. So most of them have had a severe neurologic injury, but they do not meet those criteria. They would like to donate their organs, their family would like to donate their organs, so then they go down that pathway. So there's the withdrawal of life-sustaining support, which leads to really asystole or circulatory cessation. And then if it's within that time frame, then they proceed to the operating room for organ recovery. If not, there is no organ recovery. So there are two methods, as previously discussed, both thoracoabdominal normothermic regional perfusion and direct procurement and perfusion. There's the withdrawal of life-sustaining support and then circulatory arrest, and then there's a 2 to 7 minute waiting period. And I say 2 to 7 because it really depends on where you go in this country and which hospital you're at, and is determined by the hospital, not by the OPO, not by any of the teams involved. So in thoracoabdominal normothermic regional perfusion, there is occlusion of the arch vessels and then cannulation for mechanical circulatory support. And then the heart is weaned from support and assessed, and then cold preservation. For DPP, very quickly, the chest is entered, blood is collected for the organ care system, and then cold preservation solution is administered, and the heart is put on currently the only FDA-approved device, the OCS, and then rearrested with the solution prior to implantation. One of the most important things we talk about in this process is functional warm ischemic time. So this is a debatable topic around the world. After withdrawal of life support, the functional warm ischemic time starts. We have determined to say when the systolic blood pressure is less than 50 millimeters of mercury. That is again debatable by our colleagues around the world. You can proceed to circulatory arrest and then the standoff period and sternotomy and preparation. And so this functional warm ischemic time is critical. It's the period of time where the heart is not getting adequate blood flow and oxygenation. And as we saw before, ADP stores go way, way down. Why do we know this works? Well, the first DCD transplant was done at St. Vincent's by Dr. Detal and their team in 2014. If you look at the two centers outside the U.S. doing the majority of the work before we started in this country, St. Vincent's and Papworth, they both have had excellent longer-term survival. So you look at St. Vincent's, no significant difference in 1 to 5 year survival. The same thing at Papworth, where they had a mixture of both DPP and NRP. They showed equivalent survival and possibly some benefit to NRP, including decreased use of mechanical circulatory support after transplantation, and possibly increased survival, although again the numbers are low. So in this country, a few years ago, we started this US DCD trial, and the results were presented on April 29th at ISHLT. So the trial was designed to randomize people either to DCD possible or DBD or standard of care transplantation. So obviously, if you went into the DCD possible arm, if a normal standard of care heart came up for you, were going to get transplanted with this. So there was the opportunity for those patients to cross back over to the brain dead donor controls. There were some protocol violations, so we looked at the results, looking at both the 90 and 90 that were supposed to be in their original groups, but with protocol violations, we compared 80 DCD and 86 DBD. The important part is that no matter how you looked at the results were excellent. Here are the 6-month patient survival of 95 and 89 in the per protocol evaluation, and then 94 versus 89 in intention to treat. The incidence of severe LV or RV-PGD was higher in the per protocol and the intention to treat groups, although not statistically significantly different. And I think when we look at these results in terms of time, the use of mechanical circulatory support has gone way down as we've gotten more used to the way these hearts act. And Peter McDonald from Sydney has coined the phrase, or borrowed the phrase from the kidney folks, of delayed graft function. I think everyone in the audience who's been involved in these transplants, it's a slightly different process. These hearts wake up a little bit differently, and that there's a certain percentage that have this delayed graft function, as opposed to the PGD that we saw 5 years ago, needing mechanical circulatory support or retransplantation after weeks. Looking at the Kaplan-Meier curves for both groups, again, the DCD arm showed excellent survival compared to the brain-dead donor group. So the objective was obviously to review the existing literature and worldwide experience. These are obviously just suggestions rather than outright recommendations, and we used the Delphi method to determine the class of recommendation and the level of evidence using an 80% vote and 75% agreement rule. I put this up here. This is the writing group membership, and importantly, the centers represented by these members have done over approximately 3/4 of the DCD transplants worldwide, and so truly experts in this field. The document sections really evaluate DCD donation from really the beginning to end. So brain death donation shortage, preclinical work, the ethical and legal concerns, all the way down to the outcomes and the gaps in knowledge that we have. I'm going to discuss just a couple of these rather than go through. We could spend 15 minutes on all of them, and as somebody previously said, we could spend days talking about the ethics, although it would be an inappropriate discussion, and I'll let you know why. So models to predict timely circulatory arrest are very poor, and you can see the factors that we think are associated with early circulatory arrest after withdrawal of life support. The interesting thing is there are some models to predict the donor having circulatory arrest after withdrawal of life support, but those are all used mainly for the abdominal transplant teams, and they generally start with from the time of withdrawal of life support, extubation, rather than what we want to know is when does the functional ischemic time start. And importantly, I think we will get more and more data as more of these transplants occur. The functional warm ischemic time for the heart begins when the systolic blood pressure is less than 50. Oxygen saturation is not a reliable indicator. Anybody who's ever been to the OR knows that the O2 sat is never reliable. It depends on where the finger is, and we found that in procurements that is incredibly unreliable. The functional warm ischemic time ends after cold flush or reperfusion of the heart, depending on the two methods. And then global warm ischemic time beyond 30 minutes may cause irreversible myocardial injury and should be avoided. Large animal and isolated human experiments have demonstrated this, that hearts recoverable with warm ischemic time up to 30 minutes seem reasonable. This is, again, a very debatable topic, and it depends on who you ask. So the ethical issues. So once death has been declared, there should be no reestablishment of blood flow to the brain. You have to be 100% clear here. This is really in response to other people's ideas about this topic, really people who have no idea what they're talking about. If you ask the medical ethicist, I gave a talk in 2015 as a surgical fellow, and Phil Rosoff, who's a medical ethicist and expert in this topic, stood up and said there are no ethical issues. And the reason why we clamp the head vessels is not because of this issue of death, but really to prevent the massive Cushing response that will occur. Arthur Kaplan from Harvard has said that the resumption of regional thoracic circulation does not contravene the diagnosis of death. Current techniques are directed at regional reperfusion of only the organs to be transplanted. Clamping the arch vessels is not to secure brain death, as the patient has already been declared dead on the basis of circulatory cessation. And this is an important topic for us to continue to keep in mind, that the emotional argument here is different than the ethical one. The ethical one has already been decided. And so future needs, in addition to the ones that I've discussed, so standardization of withdrawal practices, involvement of palliative care prior to even the plan to withdraw life support, location of withdrawal, using asystole versus PA or both, standoff times, etc. We as societies, ISHLT, AATS, STS actually need to get involved and take this back. You go on these procurements, and these policies are 100% determined by the donor hospitals. And these are really determined by the OR charge nurse in the donor hospital, oftentimes, it seems like. And so I think as societies, we actually need to be much more involved and standardize this practice so that this becomes more standard for everybody. The comparison of functional warm ischemic time, this is debatable, and we will learn a lot more. And I think, importantly, it's one variable in this whole process. The recipient variables, the donor variables, and then the warm ischemic time, the method of procurement. But what we really need to work our way to is sort of a sort of donor-recipient scoring system. If you have a 22-year-old donor heart that the warm ischemic time was 41 minutes, well, that's probably totally acceptable. Now, a donor who is 48 and has a warm ischemic time of 41 may not be, but we'll have to learn that. Additionally, the group from Sydney has presented some very interesting data, not only on the functional warm ischemic time, but the asystolic warm ischemic time, so the time from asystole to reperfusion. And they think that this is actually more predictive of a worse outcome, and that'll be interesting to understand that. The comparison of thoracoabdominal, normothermic regional perfusion, and direct procurement and perfusion. I have no doubt in my mind that there's going to be benefits to one versus the other. But we have to gather that data and learn from it. And then obviously the effect of both methods of procurement on other transplanted organs, because we don't live in a bubble. And we need to keep that in. The most important thing is that the most organs get used at a time. Thank you very much. Oh, sorry. I would like to thank obviously the writing group and the reviewers, and most importantly, I'd like to thank Jill Kolsch from the AATS, who really herded the cats over periods of months and did an amazing job. Thank you so much.
Jacob, nice presentation. We all recognize your efforts in leading the charge on DCD in this country. With respect, I completely disagree with you about the ethical issues. I think there are major ethical issues, and you speak of a single medical ethicist as if that's the end-all be-all of the question. You showed on your slide that 2 to 5 minutes, depending on where you go. I suspect that's because different medical ethicists at different centers have different opinions on it. My understanding of the 5 minutes is 5 minutes came from the fact that no adult patient ever resumed vitals after 5 minutes of downtime. That's not true of 2 minutes. And 5 minutes is one of the justifications used for that's why it's okay to reestablish circulation even if you're clamping the head, because after 5 minutes it shouldn't be an issue. But at some places it's 2 minutes. And what if at another place it's 0 minutes? So I think the AATS missed an opportunity to try to sort of rally us together and to come up with some benchmarks of what we feel it should be, because these are all cardiac surgeons doing these operations, and most of the procurement people are cardiac surgeons, at least doing this stuff. So we ought to be of one mind and one voice on the topic. Otherwise, I think there's a possibility that public opinion could shift. There are places, colocalization I find can be problematic. Cannulating the groin vessels before death I find problematic, but that's all being done around the country and around the world. We should get together and talk about that.
No, absolutely. No, I totally agree. And that's what I meant. We need to standardize this. And the question is, how do we best standardize? And I also agree. I mean, I think that 5 minutes you're absolutely right. It's based on sort of one report. And we do need to standardize this. We need to do this the same way so that, as you say. But that's not an ethical issue, though. That's not the ethical issue of death and the declaration of death and what death, the permanence of death, frankly.
There's a legal problem with the definition of death.
Yeah. Yes.
Some people don't think that's an issue, but others do.
Yeah.
Yeah.
Yeah, I mean, I'll just tell you, it took us a year to get approval from we've been doing DPP for a long time, and over a year for our lawyers to say, okay, because of the definition of death in the state of North Carolina alone. So, next question.
Hi, David Joyce from Milwaukee. Really enjoyed your presentation. I agree with the importance of standardization, but I think the tier 1 issue is actually the PEA versus asystole issue. And I'd like to just share my own experience for people that are looking to take this on. Oftentimes the hospitals that are the most progressive in terms of adopting NRP, for example, also have the 2-minute, they're more likely, I think, to be in the 2-minute camp, and actually in a large number of cases, they will pronounce at even 2 minutes of PEA. And the reason that's a problem is that you should expect to see a beating heart when you open the pericardium. And so, although we all understand that death resides in the brain and that the patient has already been pronounced, we also want to make sure that the lay community that maybe still has some emotional attachment to a beating heart may have reservations about organ donation if it gets out that we're taking beating hearts. So that has been a real challenge. The procurements that I've been on, we've had to actually abandon all the organs when we've encountered that situation because of concerns raised by other team members. And I just think that the most important thing we can do is really come down as a group and say, and I guess in my opinion, the safe place is 5 minutes of asystole, because you and I both know these organs are going to be just fine with that. And just have that be the standard so that we don't run into a negotiation with the liver team where they're always tied to the 30-minute window, and then you get into these really difficult situations. So thanks again. Good job.
Absolutely. I think the one thing we also can't forget is that this process isn't just about transplanting people. It's also about honoring the wishes of the donor, honestly. And these donors are going to die, except for a tiny fraction of them that will not pass away and go back to the ICU and then die somewhere else. But we have to continue to think about, in this time of tragedy for them and their family, to honor their wishes to save lives. No.
That's a justification for the practice, but it's not a good idea.
So my question, I'll resurface to you.
Yeah.
How many neurologists does it take to declare one of these donors as irreparably harmed? And
yeah, I mean, your question is a really, really good one. And because we're not talking about necessarily a neurologist in Chicago or Durham or at Mass General. We're talking about a neurologist who, in the middle of the night on the weekend, in the middle of nowhere. And so it is a really tough question. Who goes that way? And I also have a major concern about the OPO's practice, because what I've seen for us is a shift that we're seeing all these DCD donors that 2 years ago. Probably if a percentage of them, and I don't know what percentage, 25% probably would have progressed to brain death. And it's a troubling that suddenly the OPOs seem to be pushing these to go over very quickly to the operating room as DC donation, because frankly it saves them money. They don't have to do any tests, and they place more organs. So I don't know how to answer that question honestly.